and Dr. Akashdeep sir for as our speaker. And today's meeting there is two talk only. One is the first talk is from Dr. Demalla Das sir. He is a senior retina surgeon from Shankar Netralaya, Kolkata, New Town. And sir is talking about translating the research into practice, real world applications of diabetic macular edema management strategy. So I would like to request Demalla sir to kindly proceed with your presentation. Thank you, sir.
Thank you, and I will just start. I'll just share. Is it visible?
Yes,
Hello.
sir. Yeah, it's visible, sir.
Yeah. So good evening, everybody. I'll be talking about how we translate research findings into real-world clinical practice in the management of diabetic macular edema. And I'm Dr. Demalla Das. So we know that randomized clinical trials are considered as the gold standard for evaluating any therapeutic efficacy. But there is a problem. Actually, three. So first is that there are strict inclusion and exclusion criteria, which means that the trial population often do not reflect the patients we see in our day-to-day practice. Second, there is no universal consensus regarding the optimal treatment regimen. Some of us use PRN regimen, some of us use treat and extend regimens, which is not to be done. It has to follow a strict protocol if we are following the randomized control trial strategy. And according to them, we should follow whatever we has been asked for. But generally, in our real world environment, we are unable to do so because of many factors. And third is that the environment is also very highly controlled. Whereas in real world, clinical practice involves various variable compliances. Patients reports to you late. Patient has a lot of comorbidities. Most of them are uncontrolled, and the follow-up patterns are very irregular. Therefore, while randomized control trial establish efficacy, they are not always shows us the real world effectiveness. Now we know that there are many anti-VEGFs in the market that forms the cornerstone of diabetic macular edema treatment, like ranibizumab, aflibercept, brolucizumab, faricimab, bevacizumab, and biosimilars. And landmark trials like the RISE and RIDE study for ranibizumab, Yosemite trial, and the KITE trial for faricimab and brolucizumab, respectively, they have established these injections into the world as a treatment for diabetic macular edema. But if you carefully see into these studies, most of them have not gone beyond 96 weeks. However, in VIVID and VISTA style and DRCR net protocol T studies, the aflibercept has constantly shown strong efficacy across several of these studies over a long period of time. So this shows that aflibercept can maintain a vision for a prolonged period of time if initially taken in an aggressive manner and then gradually taper down as to need basis or PRN basis. Why real world evidence matters? Now this brings us to the concept of real world evidence. Now real world data is derived from routine clinical practice, unlike theoretical practice, which we generally tend to see in randomized control trial, which are highly organized. So this data, the real world evidences, this data helps us in understanding treatment effectiveness in unselected populations, long-term treatment burden, physician decision-making patterns, and outcomes in patients with comorbidities. Thus, real-world evidences complements RCT data and guides practical treatment of decisions which are actually theoretical in the making when you follow randomized control trial. An example of this is the endurance trial. What they did is that they have the real-time, long-term, real-world follow-up of the VISTA trial. And they found the visual acuity gain achieved in the initial trials were maintained over 5 years. And interestingly, by the 5th year, patients required only about 3.4 injection on the average, demonstrating a substantial reduction in the treatment burden once disease stability is achieved. And in further studies, such as the Apollon and the Moorfield studies, they have found that visual acuity improvement in real-world study closely mirror those observed in the randomized control trial. Importantly, they highlight that early intensive therapy followed by individualized treatment strategies can reproduce RCT-like outcomes in routine practice.
Sir,
Similarly,
sorry,
in a study which was conducted in UK,
sir, sorry to
evaluated
interrupt.
outcomes of aflibercept therapy, and the results showed most patients achieved vision gain or maintained vision at the end of 1 year. And over 75% of the patient had stable diabetic retinopathy severity. Patients with base-corrected visual acuity below 70 years showed particularly meaningful visual improvements. And this reflects a scenario which we frequently encounter in our day-to-day life.
স্যার আপনার ভিডিওটা একটু স্পিকারের ভিডিওটা একটু
হ্যাঁ, একটু অ্যাকচুয়ালি প্রশ্নগুলি হচ্ছে ওই জন্য আমি করতে
তাহলে
পারছি না।
স্যার ঠিক আছে আপনার লাস্টে একটু অন করে দিন, ঠিক আছে?
ঠিক, okay. So, data from the Moorfield Eye Hospital and the registry accept the efficacy of aflibercept patient in clinical practice. So they are showing that whatever has been shown in randomized control trial, one of the injection is following the same pattern when you put them in clinical practice. So poor in real world practice, poor baseline vision is very common, unlike in randomized control trial where even better eyes, and that occurs in 2/3 of the patient. Evidence from Protocol-T and other analysis suggests that aflibercept demonstrates superior visual outcome in patients with worse baseline vision, especially in the first year of treatment. As a result, several international guidelines sorry. So as a result, several international guidelines recommend aflibercept as the preferred agent when the base-corrected visual acuity is below 69 letters. We have our own studies by our own Dr. Devdulal Chakrabarty et al., who found that in cases of chronic diabetic macular edema, when compared with dexamethasone also, both intravitreal aflibercept and dexamethasone provide similar visual and central macular thickness improvement in recalcitrant diabetic macular edema. However, intravitreal aflibercept leads to better visual gains, but requires more injection and follow-ups compared to the dexamethasone group. But the dexamethasone group has another problem. So there, in 13% of the patient, they showed a raised intraocular pressure, for which they needed a IOP lowering medication of at least one IOP lowering medications. Similarly, in a study, diabetic macular edema treatment guidelines in India, anti-VEGF therapy has been told to be more effective in improving vision in center involving diabetic macular edema than macular laser treatment. And they found that the most common reason for non-response to anti-VEGF is due to inadequate treatment as per the above protocol. And in eyes with persistent diabetic macular edema and visual acuity less than 6/12, one switch can be done. So if the patient is getting a bevacizumab, a switch to ranibizumab or aflibercept is recommended. Or if no if on ranibizumab, a switch to aflibercept is advised. So switch therapy works wonder in such cases. Now, as I said, based on this, aflibercept has been declared as the drug of choice in diabetic macular edema with baseline base-corrected visual acuity of below 69 letters. So everywhere it has been shown that the aflibercept was superior compared to the other injections when it comes to worse baseline visual acuity. So a Cochrane meta-analysis, this is known as a comparative evidence. So a large Cochrane meta-analysis included more than 6,000 patients, which further evaluated anti-VEGF therapies. And what did they show? that aflibercept significantly favored visual acuity improvement at 1 year of treatment, and patients were about 30% more likely to gain 3 lines of vision, as I told you, compared to ranibizumab or bevacizumab. And these findings support the efficacy of aflibercept, particularly in more severe cases of diabetic macular edema. So all the guidelines like EURETINA, Asian Recommendation, Diabetic Canada guidelines, and German Ophthalmology Society guidelines, they all say that there is an efficacy. The aflibercept works wonder when the baseline visual acuity is less, along with dexamethasone. Can you hear me?
Yes, sir. Yes, sir.
Yeah. So all these injections, when they compared with all the injections and through the various protocols, they found that the real world evidences, as well as randomized control trial, all points toward aflibercept if you compare all the other anti-VEGFs that are there in the market. So they have recommended aflibercept. In many cases, they give aflibercept, especially in UK. They give aflibercept whenever there's a worsening of diabetic macular edema or patients when they present to the clinic with a worse visual acuity. And we know that there are evidences, level of evidences-based medicine. The lowest evidences are the editorials or the expert opinion, followed by the case series and the case report. The highest level of evidences is the meta-analysis, which they had done. So while interpreting data, we should consider the hierarchy of the evidence. Randomized clinical trials occupy the top evidences of pyramid, but real-world studies provide essential complementary information. So for clinical, optimal decision making involves integrating the randomized control trial data, real world outcomes, and individual patient characteristic. We should not only go by what the paper says. We should also keep our judgment as well as remember the real world outcomes and the papers that are pointing towards the injection that favors the patient's diabetic macular edema management. So there are a lot of ongoing DRCR network, retina network protocols going on, and in most of them, they are using or comparing aflibercept, which has since now become one of the gold standard treatment of diabetic macular edema. Like we have the protocol T, protocol V, protocol W, protocol AB, and AC. So all these are comparing aflibercept with the other anti-VEGFs, aflibercept with laser. They're even comparing vitrectomy for vitreous hemorrhage with anti-VEGF. Here they also are using aflibercept as a compression injection. So that shows the superiority of aflibercept when it comes to intravitreal injections in chronic as well as in diabetic macular edema in real world. So to conclude, anti-VEGF therapy remains the first line of treatment for center involving diabetic macular edema. Randomized control trial demonstrates strong efficacy, but real-world evidence is critical for understanding practical effectiveness. And data from multiple studies suggests that aflibercept provides robust visual outcome, particularly in patients with poor visual outline, baseline vision. Integrating randomized control trial evidence with real-world experience allows us to deliver more personalized and effective diabetic macular management. Thank you.
Thank
Can
you,
you hear
sir.
me?
Yes, thank you, sir, for the wonderful presentation. And 1 minute, sir. Yeah. And the next talk is from Dr. Akashdeep. And Dr. Akashdeep is a senior retina surgeon in Siliguri. He has his own institute, Trident Eye Institute. And sir is talking about diabetic macular edema from understanding to treatment. So I would like to request Akashdeep sir to kindly present his presentation. Akashdeep sir is there. Let me. Uh, I think he is not there. He is there, but now he is not there. I will call him. So Dr. Akashdeep sir will join. Actually, there is some technical glitch in his laptop. So he is joining within 3 4 minutes. Meanwhile, I would like to request from our audience if there is any question on sir's topic, then they can ask. So Dr. Akashdeep sir is there. I think. Hello, Akashdeep sir. बताऊं? अच्छा, टेक टीम, hello,
Yes, sir.
technical team. Yeah, kindly guide Dr. Akashdeep to share his screen. He is presenting from. सर आप किस में से प्रेजेंट कर रहे हैं, थोड़ा सा बोल दीजिए टेक टीम को। लैपटॉप या आईपैड? लैपटॉप से। ओके। आकाश सर, आप थोड़ा सा टेक टीम को बोल दीजिए, ये लैपटॉप से कर रहे हैं सर।
ओके सर।
हाँ
तो
थोड़ा।
पहले सर जूम को मिनिमाइज करिए। हेलो।
जूम को ना।
यस सर।
हाँ।
फिर अपना प्रेजेंटेशन ओपन कीजिए।
हाँ हो रहा है, हो रहा है।
यस सर।
ये हो रहा है, ब्राउजर। आ गया, आ गया, आ गया,
ओके।
आ गया। सर आप म्यूट में हैं।
हाँ, दिख रहा है तुमको स्क्रीन?
अच्छा टेक टीम, सर का तो स्क्रीन व्यू हो रहा है हमको, लेकिन सर को स्क्रीन नहीं दिखाई दे रहा है, वो क्यों हो रहा है? लैपटॉप में है।
सॉरी सर।
द स्क्रीन इज विजिबल टू अस बट इट वाज नॉट विजिबल टू द प्रेजेंटर।
जस्ट क्लिक एंड नेक्स्ट।
क्या नेक्स्ट कुछ ऑप्शन है सर वहां पे? नेक्स्ट। हाँ।
पहले सर स्लाइड को फुल स्क्रीन में कर दीजिए। राइट
हाँ,
साइड पे आपको ऑप्शन देखेगा।
राइट साइड में।
नीचे लास्ट में देखो।
व्यू में जाना है क्या? टेक्निक टेक टीम व्यू।
नहीं नहीं,
हाँ,
फुल स्क्रीन में सर।
फुल स्क्रीन।
हाँ, प्रेजेंटेशन को फुल स्क्रीन में कर दीजिए फिलहाल।
उसमें फुल स्क्रीन का कोई ऑप्शन आ रहा है सर? हम्म।
राइट साइड पे लास्ट में, राइट साइड पे देखो ऑप्शन होगा।
आपको तो
छोटा
स्क्रीन,
सा आइकन, आइकन है ना, वो वहां पर क्लिक कीजिए सर।
ये जो स्क्रीन दिखाई दे रहा है यहाँ पे, कहाँ पे है वो आइकॉन?
नीचे आइए सर, नीचे नीचे नीचे। 97 लिखा है परसेंटेज, 97%। उसके पास में देखिए।
राइट या लेफ्ट?
राइट साइड।
राइट में 97%। हाँ हाँ।
हाँ
उसमें
हाँ।
उसमें जो वो प्लस के सामने बड़ा सा बॉक्स है, ओ नहीं नहीं
हाँ
वो।
वहां पर, हाँ वहां पर क्लिक कीजिए।
हाँ
फुल
हाँ,
स्क्रीन हो जाएगा।
उसमें क्लिक कीजिए, एकदम लास्ट वाले में। जी। हम्म। अच्छा टेक टीम, ये सर को थोड़ा स्लाइड चलाने में प्रॉब्लम हो रहा है, तो मैं स्लाइड आपको भेज दूं क्या? आप चला देंगे थोड़ा सर के बिहाफ में?
नहीं सर, स्लाइड्स तो सर आपकी तरफ से मैं हेल्प करता हूँ ना सर, कैसे
Saurabh,
स्लाइड शेयर।
Saurabh,
हाँ
Saurabh, you
हाँ।
just request the doctor to send you the slide. If you have the slide, you just share it, and doctor will talk on
ओके
the
ओके
slide.
ओके ओके।
Doctor will.
सो अच्छा टेक टीम, तो मैं आईपैड में हूँ अभी, तो
ओके
मैं
सर।
अभी शेयर ऑप्शन में क्लिक किया, यहाँ स्क्रीन, फोटो, शेयर कैमरा, आई क्लाउड और वेबसाइट यूआरएल आ रहा है। अब किस में क्लिक करना है बोलिए?
नहीं सर, पहले आप अपना प्रेजेंटेशन है ना, वो शेयर
हम्म।
कीजिए।
प्रेजेंटेशन।
फिर जूम जूम में है ना,
हाँ।
शेयर स्क्रीन का ऑप्शन होगा।
अच्छा मैंने प्रेजेंटेशन का पीपीटी में क्लिक कर दिया है। अब क्या
आकाश
करना
सर
है?
शेयर स्क्रीन कर रहे हैं सर।
शेयर स्क्रीन,
हाँ।
मतलब स्क्रीन वाले ऑप्शन में क्लिक करना है, क्लिक करना है। एक सेकंड, एक सेकंड। स्टार्ट ब्रॉडकास्ट, स्टार्ट ब्रॉडकास्ट। दो दो आवाज में, दो दो आवाज
Saurabh,
में।
I think Saurabh, I think that is sharing the
That is
screen.
sharing the screen.
I think double
I
sharing is
think
not
double
allowed.
sharing is not allowed in. Okay, 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 okay.
Sir already shared the
Sir
screen.
already
Okay.
shared the screen. Okay. Right, right, right.
Right,
ठीक है
right,
सर,
right.
अभी
ठीक है
आपका आ
सर,
रहा है।
अभी आपका आ रहा है।
Sir, you are muted.
Sir, you are muted.
हाँ, अभी आ रहा है। ओके, क्या करना है? आ रहा है तो नहीं, कोई शेयर कर रहा है क्या स्लाइड को? बट इट्स नॉट मूविंग, यही तो प्रॉब्लम है। आई कांट अंडरस्टैंड।
This presentation is not visible to the speaker. That's why I am presenting on behalf of the speaker, and speaker will narrate according to that. So I am going to share my screen first. Okay, start share. Yes. So this is the presentation. I think it is visible. Hello, visible है टेक टीम?
नो सर, आपकी जूम की स्क्रीन दिख रही है सर, प्रेजेंटेशन नहीं दिख रहा है।
ये प्रेजेंटेशन, अच्छा, यू आर शेयरिंग स्क्रीन, तो प्रेजेंटेशन कैसे दिखाऊं मैं?
पहले आप अपना प्रेजेंटेशन ओपन कीजिए
ओपन है, ओपन है।
आईपैड में।
अच्छा,
फिर
ये दिखाई दे रहा है अभी?
यस सर, परफेक्ट।
Okay, okay. So Akashdeep sir, kindly unmute and I will share the presentation accordingly. And I would like to request Abhishek, our buyer colleague, to take the screenshot.
Okay, sure. Okay, I will take.
Because here I am only seeing the presentation, not the entire
Okay, okay.
screen. Yeah. Akash sir, you can present. हाँ सर, बोलिए। हाँ, अभी तो आ रहा है स्क्रीन में, आप बोलिए। अभी स्क्रीन आपको दिखाई दे रहा है ना? आपको स्क्रीन दिखाई नहीं दे रहा है? ये देखिए ना सर, अभी हो रहा है ना, अभी मूव हो रहा है, देखिए। मतलब आपके लैपटॉप में मूव नहीं हो रहा है? ओहो, तो आप एक बार लॉग आउट करके लॉग इन कीजिए ना सर। अच्छा। आ, आपको ये हमारा स्क्रीन तो दिखाई दे रहा होगा। हाँ, आप स्टॉप शेयरिंग कीजिए। स्टॉप शेयरिंग हो रहा है ना सर? हाँ, मैंने शेयर कर दिया स्क्रीन, वो तो दिखाई दे रहा है सबको। हम्म, जी। आप नहीं तो मोबाइल में लिंक में क्लिक करके ये कीजिए, तो आपको स्क्रीन भी दिखाई देगा। हाँ हाँ, आपको मैंने मोबाइल में लिंक भेजा है व्हाट्सएप में, उसमें आप क्लिक करके ऑन कीजिए, आपको स्क्रीन दिखाई देगा। हम्म, देखा सर? दिख रहा है? अच्छा, ये अभी मूव हो रहा है सर। ओके, आप यहाँ आप शुरू कर दीजिए। हाँ हाँ, राइट राइट राइट, आप माइक ऑन करके आप बात कर लीजिए। जी। हाँ हाँ हाँ, ठीक है ठीक है। आपका आवाज तो इसमें आएगा, तो मैं उस हिसाब से इसको स्लाइड चेंज करता रहूंगा। जी जी। यहाँ से आप देख के भी बोल सकते हैं। हम्म। मोबाइल में ना। हाँ। जी जी। हाँ सर। हाँ, फोन काट के आप, मतलब आप MS टीम में आप बोलेंगे। जी 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 जी। ओके सर, आप स्टार्ट कीजिए अनम्यूट करके, राइट। हाँ। ओके। So, sorry for the inconvenience, our audience. Because of some technical issue, this was happened, and sir has shared the screenshot of the laptop also. There is genuinely there is some problem. So I would like to reintroduce Dr. Akashdeep sir. He is a senior veterinary surgeon in Siliguri, and sir is talking about diabetic macular edema from understanding to treatment. Sir, kindly start your talk.
Yeah, good evening, everyone. I'm very sorry for the technical issue and delay. So, I'll be talking today on diabetic macular edema from understanding to treatment. So, first, if we see the burden of diabetes, so if we focus the global burden of diabetes coming to Southeast Asia, we have seen that there is 74% increase in the global burden of diabetes in Southeast Asia. So it is one of the highest in among the other regions, among second highest, you can say. So what is actually diabetic macular edema? Diabetic macular edema is basically because of the leakage of fluid and proteins in the macula, which causes the fluid accumulation in the macular area. It mainly the main factor causing this is VEGF-A, which actually causes disrupts the blood retinal barrier and increases the vascular permeability. Everyone knows this. So there are other factors also other than VEGF-A like PIGF and VEGF-B. So basically, the diabetic macular edema occurs in both type 1, can occur in both type 1 and type 2 diabetes mellitus. So vision loss basically happens in diabetic macular edema, and in the mainly the work it mainly affects the working group population, and the working group population basically the it hampers their daily activities, and just like some people performing the near vision tasks, others who are driving, they are also very much affected with this. And you can say people have difficulty in having the color vision. There's perceiving the different colors. The colors cannot be perceived very nicely. That there's quite some difficulty in reading. Okay, and even it increases the mortality risk compared to other normal individuals. So basically, diabetic macular edema can happen at any stage of diabetic retinopathy, from moderate to severe to proliferative. Okay, and if it is not taken care of, it causes severe visual impairment. So the treatment of diabetic macular edema has evolved over time, and actually anti-VEGF is the main treatment, current standard of treatment of diabetic macular edema. So starting the three main treatment are lasers, anti-VEGF, and steroids. So we know the this tree which starts from laser photocoagulation, which started in 1985 uh, till yeah. So then came the ranibizumab thing, ranibizumab molecule, which were well established with the RISE and RIGHT study. Then there came the dexamethasone Orzudex, which was approved in 2014, and the MEET study demonstrated its efficacy and all. So aflibercept came in 2014, which was the Vivid and Vista study proved its efficacy, and basically its mm, usage much. So, and in 2022, we got the faricimab, which was which this study is called KITE studies and Yoshimoto studies. They just came with the faricimab molecule, and now in 2023 we got the aflibercept 8 mg molecule, which got approved in 2023. So, what are the key factors? What are the key factors behind the key mechanisms behind the pathogenesis of diabetic macular edema? So mainly the VEGF-A and PIGF, they act on the VEGF receptors to promote the vascular leakage. They causes the vascular leakage and edema and inflammation and neovascularization. So if we come to the basic mechanism, there is usually the vessel occlusion, which causes impaired blood flow, which causes hypoxia, and this hypoxia leads to increase in formation of this inflammatory factors, as well as this VEGF factors, which causes the breakdown of the blood retinal barrier. And with the breakdown of the blood retinal barrier, there is leakage of this proteins and fluid in the retina. So mainly this VEGF basically acts by VEGF-1 and VEGF-2 receptors, and PIGF acts on VEGF-1 receptor only. So aflibercept is the only molecule which anti-VEGF agent which acts on almost all of these receptors: VEGF-A receptor, VEGF-B receptor, and PIGF. Other molecules do not act on all the receptors. So even if VEGF-A is completely blocked, VEGF-B and VEGF-PIGF receptors are still available to bind. And, um, and continue the other effects. But with the usage of aflibercept, we can control all these receptors. So mainly VEGF A, VEGF B, and PIGF, they are the main factors behind the pathogenesis of diabetic macular edema, and aflibercept is the only molecule which which is the only anti-VEGF agents which targets all these mediators. So coming to the what evidence we have in support of this anti-VEGF. So there are randomized controlled trials. We have real world evidences. We have lot of meta-analysis, even our own experience via patients, and the mode of action and various international guidelines. So now coming to Vivid and Vista, what did Vivid and Vista actually show about the aflibercept in DME? We all know about this Vivid and Vista, but I'll just come to the concluding points. In Vivid and Vista, we have just marked the important points in the red lines. They have shown that the clinically meaningful vision gains were achieved in patients who had early and intensive treatment with aflibercept. You can see in both this graph that and the persons receiving aflibercept at 8 weekly intervals with the initial loading dose and 8 weekly intervals, they have maintained a vision of 10.7 and 12.5 in Vivid and Vista studies, and which is far much superior to the laser group. So even in Vivid Vista and Protocol T, it was also seen that the meaningful vision gain were achieved in patients who had received early and intensive treatment with aflibercept. So vision gains were it concluded the vision gains were observed uh, very early with the first aflibercept injection only, and the patients who had received more than 8 injections throughout 1 year and maintained vision gains um, achieved that they achieved during the initial loading dose only. Again, if we consider all these three studies, we have seen that the patients treated with aflibercept has gained more than 10 letters, and at the end of the 52 weeks, aflibercept has demonstrated its superiority to laser, in which has shown clearly in Vivid and Vista study. So even this study also showed that delaying aflibercept treatment had led to poor vision outcomes. If you see these graphs, so if you the difference, you can see a huge difference between the laser and the aflibercept group. So coming to the other evidence, like what does meta-analysis and various international guidelines recommend for the treatment of DME? So a Cochrane meta-analysis was done to basically a Cochrane meta-analysis reviewed the evidence from major studies in the efficacy of various anti-VEGF agents, and actually they found that at the end of 1 year, all the efficacy outcomes were in favor of aflibercept over ranibizumab and bevacizumab, and patients have gained more than 3 lines. 30% of patients have gained more than 3 lines with aflibercept than with the ranibizumab and bevacizumab group at the end of 1 year. So other meta-analysis are also done, which had proved that aflibercept is the most favorable treatment for the patients with DME. So aflibercept, when given at the 8 weekly interval, they have showed consistent and superior results with the ranibizumab 0.5 mg given at PRN. So we can tell that aflibercept is the most favorable treatment in terms of both BCVA improvement as well as in case of CMT reduction in the as compared to other therapies in the management of DME. So this therefore various guidelines of EURETINA guidelines in 2017, Asian recommendations in 2018, Diabetes Canada guidelines, and German ophthalmological guidelines of 2019. There, so if you come to EURETINA guidelines, if you can, they have in DME eyes with best corrected visual acuity below 669 letters or 20 by 40 words. And it has shown its superiority compared to bevacizumab over 2 years and over ranibizumab in the first year of treatment. So if you, what does Asian recommendation show? It says that in patients with visual acuity worse than 6 by 12, aflibercept may result in a more rapid visual improvement than ranibizumab over 1 year. So, and coming to Diabetes Canada guidelines, they have shown that the superiority of aflibercept was noted in the group of participants with the worst visual acuity. That means the group of patients having worse visual acuity. In those cases, aflibercept had a superior hand. And same as for German ophthalmological guidelines, they also shown there is the evidence of possible difference in the drug efficacy in patients with diabetic macular edema to the disadvantage of bevacizumab. So in summary, we can say that aflibercept can achieve meaningful visual gains in patients with diabetic macular edema, and various meta-analysis and international guidelines and other recommendations also suggest that aflibercept should actually be the drug of choice when you treat a patient with baseline visual acuity less than 20/40 or less than 69 letters. Even the real world evidence studies highlights the effectiveness of aflibercept in the clinic, but regularly patients with poor vision less than 69 letters. So patients with visual impairment due to DME and with vision less than 20/40 can actually start with aflibercept, and aflibercept is better than the other anti-VEGF agents in real world clinical practice. Thank you.
Thank you, sir. So, thank you, sir, for your
Thank you.
presentation. And we would like to now the platform is open for a discussion. If there is any question from the audience side or speaker side, they can ask. And we will wait for another 2 to 3 minutes. And if there is no question, we will close the meeting. So no question is there. So thank you very much, both of our speakers, Dr. Demalada sir and Dr. Akashdeep sir, for the presentation. And so we are good to close now. So I would like to request Tech Team to kindly close the